You know that feeling when you're sitting in a doctor's office and they hand you that clipboard? Or maybe they're just, like, grilling you in person?
Oh, yeah. The endless intake forms.
Right. And they ask for what feels like the 100th time about every single thing you take. And not just your prescriptions, but, the over-the-counter stuff, the vitamins, your daily habits.
It definitely feels like bureaucratic box checking to a lot of people.
Exactly. It can feel so tedious. Like, yes, doc, I occasionally take an ibuprofen for my knee. Can we please move on to why I'm actually here?
A seemingly endless list of questions that just, well, they don't appear relevant to your immediate complaint at all.
But today, we're going to reveal exactly why those seemingly tedious questions are literally a matter of life and death. So, welcome to this deep dive.
Thanks. I'm excited to get into this one.
Today, we're looking at a super essential clinical guide. It was published in March 2026 by the PsycNP Fellowship, and it's titled Psychiatric Medication Interactions Every PMHNP Should Have Memorized.
Yeah, and it's a completely foundational piece of literature for anyone managing complex psychopharmacology.
Right, because the goal of this deep dive isn't just to, list a bunch of medical side effects for you.
No, the focus is entirely on the hidden microscopic domino effects, the things that occur when medications collide inside the human body.
Okay, let's unpack this, starting with the body's primary processing plant, which is the liver.
The big filter.
Exactly. Because I think we often view drug metabolism as this simple input-output mechanism, right? But the reality involves a highly specific group of enzymes called the cytochrome P450 system.
Yeah, the CYP450 system is basically the bedrock of safe medication management.
Right.
Because when you ingest a drug, your body treats it as a xenobiotic, which is just a fancy word for a foreign chemical.
Chemical invader, basically.
Exactly. And the liver's job is to oxidize that chemical so it can be safely excreted. And it does this using various CYP450 enzymes.
But it's not a smooth process, is it?
Not at all. The complexity arises because drugs don't just passively pass through this system. Many of them actively interfere with it.
They act as inhibitors, right?
Yes, they essentially bind to a specific enzyme and they prevent it from processing anything else.
Which creates a massive bottleneck. Like, if you don't understand how a drug is interacting with those specific enzymes, you are prescribing completely blind.
Precisely. Let's look at the CYP2D6 enzyme as an example.
Okay.
The guide highlights that several major psychiatric medications, so fluoxetine, paroxetine, and bupropion, they are potent inhibitors of 2D6.
They block it.
Right. So if a patient is stable on a drug metabolized by 2D6, say an antipsychotic like aripiprazole,
Yeah.
and then you add fluoxetine.
The fluoxetine basically occupies the whole enzyme.
Yes. The aripiprazole literally has nowhere to go. It backs up into the bloodstream, increasing its serum levels by a staggering 200 to 400%.
Oh, wow. So I'm picturing the CYP450 enzymes like bouncers at a very exclusive nightclub, where the nightclub is your bloodstream.
That's a great way to look at it.
Normally, the bouncer's checking IDs, letting the right amount of drug molecules into the club, and kicking the rest out, right? But a drug like fluoxetine comes along and essentially distracts the bouncer.
Gets into a long, involved conversation right at the door.
Exactly. And while the bouncer is distracted, 3 times as much of the aripiprazole sneaks right past the velvet rope and just floods the club.
That is a highly accurate way to visualize competitive inhibition.
It makes so clear.
And the clinical result of that flooded club is profound toxicity. Tripling the aripiprazole levels can induce severe sedation or akathisia.
Akathisia is that really debilitating, deep inner restlessness, right?
Yeah, it's incredibly uncomfortable for the patient. But it's crucial to understand that inhibition can also sabotage treatment in the opposite way by preventing a drug from working at all.
Wait, really? How does that work?
Take a common painkiller like codeine. Codeine is what we call a prodrug.
Meaning it's inactive when you take it.
Exactly. It is entirely inert until the 2D6 enzyme cleaves it into morphine.
Oh, I see.
So if a patient is taking paroxetine, that 2D6 enzyme is blocked, the codeine just passes through the patient's system totally unprocessed.
So it offers absolutely zero pain relief. You're just taking a useless pill.
Exactly.
But wait, I have to push back here for a second. Is this traffic jam, this distracted bouncer scenario, is it purely a pharmacy to pharmacy problem?
What do you mean?
Like, it seems like it would require a cocktail of overlapping prescription pills to cause that kind of dysfunction. Are we only worried about combining prescriptions?
What's fascinating here is that environmental factors can hijack these enzymes just as aggressively as pharmaceuticals.
No way. Like what?
The most critical example from the guide is smoking.
Just regular cigarettes.
Yeah. Let's shift from the 2D6 enzyme to CYP1A2.
Right.
We know that certain drugs, like the SSRI fluvoxamine, inhibit 1A2.
Okay.
If you combine fluvoxamine with an antipsychotic metabolized by 1A2, like clozapine or olanzapine, you get rapid, dangerous toxicity.
Yeah.
Same as the bouncer analogy. Combustible smoke, however, does the exact opposite. The polycyclic aromatic hydrocarbons in cigarette smoke act as potent inducers of the 1A2 enzyme.
Inducers. So instead of distracting the bouncer, smoking is essentially giving the bouncer a megaphone and a massive dose of caffeine.
Basically, yeah.
So they start clearing out the club much faster than normal.
That's the exact mechanism. The smoke triggers genetic expression to synthesize literally more of the 1A2 enzyme, which clears out the clozapine at an accelerated rate.
Wow, so the drug doesn't even stay in their system long enough to work.
Right. To compensate for that, a clinician actually has to prescribe a significantly higher dose of clozapine to a smoker just to reach normal therapeutic blood levels.
That's wild.
But the lethal danger isn't the smoking itself. It's the cessation.
Wait, quitting smoking is the danger?
Think about it. If the patient decides to quit smoking cold turkey, that enzyme induction suddenly wears off.
Oh, I see. The bouncer slows back down to normal speed.
Hmm.
But the patient is still taking that artificially high dose of clozapine.
Exactly. And that causes the drug levels to spike dramatically in just a matter of days.
That is terrifying.
Unless the clinician is proactively monitoring the patient's lifestyle habits and tapering the drug dose right alongside the smoking cessation, the patient can hit life-threatening toxicity.
Just from deciding to quit cigarettes.
Yeah.
That's incredible. So the liver is clearly a volatile clearance bottleneck, but let's look at what happens when drugs bypass that metabolic traffic jam entirely.
Right, moving on to receptor-level interactions.
Yeah, where they actively stack their primary effects. I'm talking about serotonin syndrome.
Yes, this represents a fundamental shift from pharmacokinetic interactions, which is how the body handles the drug,
Right.
to pharmacodynamic interactions, which is what
Yeah.
the drug actually does to the body.
Okay, that makes sense.
Serotonin is a vital neurotransmitter, obviously, but the brain has a strict safety threshold. When serotonergic activity breaches that threshold, the central nervous system basically goes into an acute, life-threatening overdrive.
And the classic triad of symptoms is pretty harrowing, according to the guide.
It is.
You have neuromuscular hyperactivity, presenting as clonus and hyperreflexia, then autonomic instability, which triggers severe hyperthermia and tachycardia, and finally, profoundly altered mental status.
Agitation, confusion, sometimes delirium.
Right. And what really stands out is how rapidly this cascade triggers.
The onset is typically within 24 hours of a medication change or a new combination.
So
It's
fast.
extremely fast. And the most severe presentation occurs when you combine an SSRI, a selective serotonin reuptake inhibitor, with an MAOI, a monoamine oxidase inhibitor.
Because an SSRI prevents the reuptake of serotonin from the synaptic cleft, leaving more of it active, right?
Right. And an MAOI destroys the actual enzyme that breaks the serotonin down.
So you are simultaneously turning on the faucet full blast and plugging the drain.
Exactly. The interaction is so catastrophic that clinical guidelines mandate a rigid 14-day complete washout period between taking these two drug classes.
14 days of taking nothing.
Yep. And for a drug like fluoxetine, due to its exceptionally long half-life, that washout period is actually extended to a full 5 weeks.
5 weeks. But I actually have to push back on this scenario just a little bit.
Oh.
Yeah, because MAOIs are older generation drugs, right? And they really aren't prescribed all that often anymore in typical outpatient settings.
That's true. They aren't the first line
Oh,
of defense.
So it feels like a bit of a rare edge case. Are you saying someone could be on a standard everyday SSRI, the kind millions of people take daily, get a migraine or a bacterial infection, take their prescribed meds, and end up in the ER with a life-threatening fever?
If we connect this to the bigger picture, the danger lies entirely in the crossover with general medicine,
Okay.
because mental health treatment does not exist in a vacuum.
Right.
A patient on a standard SSRI might visit urgent care for a bad migraine and receive a triptan, or they suffer a minor injury and get prescribed tramadol for the pain.
And those affect serotonin?
Both of those medications have significant serotonergic activity.
Wow. The guide also specifically calls out linezolid, right?
Right.
Which is an antibiotic used for resistant bacterial infections, but chemically, it possesses reversible MAOI activity.
That is the exact trap. A physician treating a skin infection isn't necessarily focused on the patient's psychiatric regimen.
They're just looking at the infection.
Right. This is why dual, triple, or quadruple drug regimens are so inherently fragile. A patient might be clinically stable on an SSRI for depression and maybe trazodone for sleep.
Okay.
The system is stressed, but it's holding. But the moment they tweak their back and take that prescribed tramadol,
That third serotonergic agent just pushes the synaptic concentration over the cliff.
exactly, straight into serotonin syndrome.
It's basically an invisible chemical collision in the brain. But these physiological side effects don't just target the nervous system, do they?
No, they don't.
If we look at the heart's electrophysiology, there's a completely different kind of stacking occurring.
We were referring to QTC prolongation here.
Right.
Every time the heart beats, its electrical system must depolarize and then repolarize. Essentially, it's recharging for the next beat.
Okay, that makes sense.
The QT interval is what measures that recharge time. Certain medications actually block the specific potassium ion channels responsible for that repolarization, and that stretches the interval out.
And if it stretches too far?
The heart's electrical rhythm can completely destabilize into torsades du point, which is a fatal ventricular arrhythmia.
And a significant number of major psychiatric medications cause this stretching, right?
The list is substantial. Antipsychotics like ziprasidone, thiordazine, and haloperidol, particularly when haloperidol is administered intravenously.
Okay.
Methadone is a major offender too. And interestingly, citalopram.
Wait, really? Citalopram is a very common SSRI.
It is, but the risk is dose-dependent, specifically when the dosage exceeds 40 milligrams.
Okay, here's where it gets really interesting, because I was thinking about the exponential danger of stacking these medications.
Go on.
Imagine you have an old, cheap extension cord in your house.
Okay.
If you plug a refrigerator into it, it's fine. The cord can handle that single load. The refrigerator is the citalopram, basically.
Right.
But then it gets cold, so you plug a space heater into the exact same cord, and then later you decide to use the microwave also plugged into that same exact cord.
I see where this is going.
Right. Any one of those appliances operates perfectly on its own. But stacking all three on a single cheap circuit guarantees you are going to blow the fuse.
The extension cord analogy perfectly captures the cumulative risk here.
It's all about stacking.
Exactly. Because the most precarious situations arise when common non-psychiatric medications act as those additional appliances.
Like what?
Say your patient taking citalopram gets food poisoning, so an ER doc administers ondansetron for the nausea.
Sofran, yeah.
Then they develop a secondary respiratory infection and receive azithromycin.
An antibiotic, both of which are mild QTC prolongers.
Exactly.
So you just plug the microwave and the space heater into the same circuit.
And what makes this clinical scenario even more treacherous is that the extension cord might already be frayed before the patient even takes that first pill. The data highlights physiological risk factors that naturally lower the threshold for a blown circuit. Things like female sex, underlying heart failure, a naturally slow heart rate,
Bradycardia.
right? Or low serum potassium and magnesium levels, which directly impair those cardiac ion channels we talked about.
Wow. That really explains the strict clinical protocol the guide lays out. You can't just prescribe and hope for the best.
Absolutely not.
The guide insists on baseline EKGs to physically measure that electrical interval, comprehensive electrolyte panels, and actually running the entire regimen through databases like Credible Meds before making a single addition.
Because treating the whole physiological system is non-negotiable.
Okay, so we have receptor stacking in the brain and we've got electrical stacking in the heart.
Yep.
Let's look at what happens when drugs have to physically leave the body and they hit a massive traffic jam at the kidneys. We're talking about lithium and sodium competition.
This is a classic but crucial interaction. Lithium remains the gold standard for bipolar disorder stabilization, but it operates on a razor-thin therapeutic index.
It's incredibly precise.
Yes, the target serum concentration sits tightly between 0.6 and 1.2 milliequivalents per liter.
That's a tiny window.
Extremely tiny. Drop below that, and the patient relapses into mania. Creep above it, and they enter acute, multi-organ toxicity.
So the margin for error is essentially zero, but the underlying mechanics of why it's so volatile come down to just basic chemistry, right? Lithium and sodium are incredibly similar.
They are. They're both alkali metals sitting in the exact same group on the periodic table. They share a very similar ionic radius.
Okay.
Because of this, the proximal tubules in the kidneys essentially cannot tell them apart. They compete for the exact same renal reabsorption pathways.
They're trying to use the exact same exit door.
Exactly. So if the body becomes depleted of sodium, the kidneys panic and begin aggressively reabsorbing any sodium they can find to maintain homeostasis.
Oh, I see.
And because they can't distinguish between the two elements, they aggressively reabsorb the lithium as well, driving the serum levels straight into the toxic range.
And the guide outlines how standard, everyday medications inadvertently triggered this exact crisis.
They do.
Like ACE inhibitors and ARBs, which are foundational blood pressure medications, they can reduce lithium clearance by 25 to 40%.
So it's a massive reduction.
Right. And thiazide diuretics trigger acute lithium toxicity by flushing sodium out of the system. Even NSAIDs, like over-the-counter ibuprofen and naproxen, reduce clearance by up to 25% by altering renal blood flow.
Though it's clinically vital to note here that aspirin does not carry this specific interaction risk.
Oh, that's good to know.
And we have to remember these interactions are bidirectional.
Meaning they work both ways.
Yes.
Yes.
Initiating an ACE inhibitor will spike lithium levels. But if a patient unilaterally decides to stop taking their blood pressure medication, the lithium clearance rate suddenly jumps.
Oh, so the drug leaves the body too fast.
Exactly.
Yeah.
Serum levels plummet, and the patient faces an imminent manic episode.
So let me get this straight. Let me put this in a real-world context for a second. Say a patient who has been perfectly stable on lithium for 5 years goes on a summer vacation.
Okay.
They spend a long day at the beach, sweating, not drinking enough water. Then they catch a mild summer flu with a fever, further dehydrating them.
The perfect storm.
Right. And to bring the fever down, they take standard over-the-counter ibuprofen for a couple of days. Is that mundane chain of events enough to turn a perfectly stable psychiatric regimen into acute poisoning?
This raises an important question about the limits of clinical oversight, because that exact scenario is actually one of the most common pathways to lithium toxicity.
Seriously?
Yes. The dehydration forces the kidneys to hoard sodium and therefore lithium. Then the ibuprofen constricts the renal arterioles, further slashing the clearance rate.
Wow.
The patient goes from stable to totally toxic in 48 hours without ever altering their psychiatric prescription.
That is genuinely terrifying.
It highlights why clinicians must document thorough lithium interaction counseling at every single visit.
Right, because the average patient doesn't view ibuprofen as a drug interaction. To them, it's just a household item they bought at a gas station.
Exactly. It's just headache medicine to them.
So if the kidneys represent a physical exit bottleneck, there is a more direct form of metabolic sabotage, right? Where one drug actively dismantles the pathway another one relies on.
Yes, our final interaction.
The guide frames the relationship between valproate and lamotrigine as one of the most clinically critical interactions in all of psychiatry to memorize.
And for good reason. Both are powerful mood stabilizers and anticonvulsants. But when administered together, valproate acts as a potent inhibitor of a metabolic process called glucuronidation.
Let me make sure I have this right. That's the process where the body attaches a sugar molecule, glucuronic acid, to a drug to make it water-soluble so it can be excreted in the urine, right?
That is exactly it. Lamotrigine relies heavily on glucuronidation for clearance. So by inhibiting the specific UGT enzymes responsible for this process, valproate effectively halts lamotrigine's exit. It immediately doubles its concentration in the patient's bloodstream.
Doubles it, which introduces a massive risk.
Right, huge risk.
Because rushing the introduction of lamotrigine normally carries a risk of Stevens-Johnson syndrome, which is a severe, potentially fatal dermatological reaction where your epidermis separates from the dermis.
It's an incredibly dangerous skin condition.
Right, so when valproate is doubling the active drug levels right off the bat, that risk just skyrockets.
Precisely. That's why the titration schedule must be radically modified if they're used together.
How slow are we talking?
If a patient is already on valproate, you initiate lamotrigine at an agonizingly slow pace. We're talking merely 25 milligrams every other day for 2 full weeks.
Wow.
Then 25 milligrams daily for the subsequent 2 weeks. And the ultimate target dose is capped at roughly half the standard amount, typically 100 to 200 milligrams instead of the usual 200 to 400.
So what does this all mean when you try to undo the combination? We know establishing the regimen is this delicate, high-stakes process. What happens if a patient just simply stops taking the valproate?
The uncoupling is just as volatile.
Really?
Oh, yeah. The moment the valproate is removed, the inhibition of glucuronidation ceases. The UGT enzymes reactivate, and the body begins metabolizing and excreting the lamotrigine at its normal, uninhibited speed.
Which means?
The patient's lamotrigine levels will plummet by 50% over the following weeks.
Just drop off a cliff.
Exactly. For a patient relying on that specific serum concentration for mood stability, a sudden 50% drop leads directly to severe psychiatric relapse.
It's a true tightrope walk. Adding or subtracting either of these medications requires incredibly precise proportional adjustments.
You're constantly monitoring blood levels to prevent toxicity, which presents as ataxia, profound dizziness, or diplopia, while simultaneously guarding against relapse.
It really forces clinicians to treat psychopharmacology not as a series of isolated dials, but as a highly complex interconnected switchboard.
That is the perfect way to summarize it.
And that brings us right back to the core premise of this entire discussion, I think. When you synthesize the data from this March 2026 clinical guide, from the competitive inhibition of liver enzymes to the synaptic overflow of serotonin,
The electrical stretching of the cardiac cycle.
and the competitive filtration in the kidneys, the undeniable takeaway for you listening is that the human body is a profoundly interconnected web.
Right, a seemingly isolated action. Whether it's treating a localized skin infection with an antibiotic, buying over-the-counter pain relievers for a sports injury, or finally breaking a nicotine addiction, it all cascades through the entire physiological system.
It has the power to completely derail a carefully calibrated psychiatric regimen.
Which empowers you to understand the actual why behind your doctor's extensive questioning.
Exactly. The next time you're sitting with that clipboard and they ask you about your vitamins, your smoking habits, and your over-the-counter pain meds, you'll know they are trying to map out your unique chemical landscape.
They need to know every single appliance you have plugged in so they don't accidentally blow a circuit.
Complete transparency is the only effective defense against these invisible physiological collisions. It's the only way to manage the risk.
Absolutely.
But I want to leave you with a final thought to mull over.
Okay, let's hear it.
We've spent this whole deep dive analyzing how specific chemical compounds interact today, right? Relying on physical blood draws, EKGs, and honestly, patient memory to catch these bottlenecks.
Right.
But as we accelerate into an era of highly personalized medicine and continuous biometric tracking, what if, very soon, our smartwatches don't just track our sleep cycles and daily steps?
Oh, wow.
What if they could actively alert us in real time when our morning coffee, a new antibiotic from urgent care, and our own unique genetic metabolic rate are combining to create a dangerous, invisible chemical storm right there in our bloodstream?
Real-time pharmacokinetic tracking. That would fundamentally rewrite the rules of medicine.
It really would. But until then, just tell your doctor about the ibuprofen. Thanks for joining us on this deep dive.